Hello, and thank you for listening to this information session from Alberta Health, providing an overview of the new continuing care legislative framework for operators and providers. These are the topics that will be covered in this presentation today, including new terminology, staffing requirements in the new legislation, goods and services, charges and fees, compliance monitoring and exemptions, and complaints. This presentation will provide an overview of the new legislation and highlight what is changing for operators and providers. The implementation of the Continuing Care Act and strategic investments to transform continuing care are a major undertaking that will help make Alberta's continuing care system more sustainable, responsive, and flexible to meet existing pressures in continuing care. So why was a new legislative framework developed? A significant reason for the new continuing care legislation is to address gaps with the previous legislation. It was complex, fragmented, and in many instances outdated. There were barriers to implementing shifts and enabling flexibility to transform the continuing care system and support Alberta's aging population. It was unclear what services were available in different settings and programs and who was responsible for the costs. Some settings were not appropriately reflected throughout the legislation, such as palliative and end-of-life care or designated supportive living. There were also gaps in reflecting the importance of resident and client quality of life. Inconsistencies and gaps for compliance monitoring existed around licensing, authority to inspect and respond to complaints, and the ability to exempt operators from specific licensing requirements. Furthermore, the COVID-19 pandemic revealed and exacerbated system-level issues across the continuing care sector. The gaps that previously existed became more apparent and concerning over the course of the pandemic. And here you can see why the previous legislative framework was so complicated. It was comprised of content from 6 acts, 6 regulations, and 3 sets of standards. In addition, some of the legislation dated back to 1985 and didn't accurately reflect the current continuing care system. Given the challenges with the previous legislation, one new overarching legislative framework was developed to regulate the full continuing care system. Recognizing the challenges with the previous legislative framework, the Government of Alberta conducted a series of engagement initiatives with stakeholders to inform the development of the Continuing Care Act, new regulations, and updated standards. In 2021, targeted stakeholder engagement on legislation was completed with key stakeholders with interest and knowledge in legislation. Participants were asked to provide written input specific to what they wanted to see and not see in the new continuing care legislation. Following the introduction of the Continuing Care Act in the spring of 2022, several virtual sessions were held to provide information about the Act and the new legislative framework overall. At the same time, we started regulation-focused working groups with over 140 subject matter experts, including operators, providers, Alberta Health Services, and staff from within the Ministry of Health, as well as from Seniors, Community and Social Services. We also included representatives from differing perspectives, such as hospice providers, service providers for persons with developmental disabilities, and the Health Advocate's Office. Alberta Health also consulted with unions to discuss workforce issues and met with a core group of operators and providers to share draft content and seek early feedback. The new legislative framework was informed by findings from reports and engagements, which included public input from residents, clients, and families, and other Albertans, including the reports listed on this slide, as well as in-person engagements in 2016. We would like to take this time and thank all of you who participated in this process. This significant milestone could not have been achieved without all your support and hard work. So on behalf of Alberta Health, thank you. This visual represents the components of the new legislative framework for the continuing care sector. The Continuing Care Act was introduced in the spring of 2022 as Bill 11 and received royal assent shortly after. The Act is the highest level of authority and identifies the scope for what's in regulation. The 2 regulations build on content in the Act and outline what government expects to be provided through continuing care. There are also associated policy tools, including ministerial orders, directives, guidelines, standards, etc., that are also part of the new legislative framework. The Act, regulation, and associated policy tools are the key foundational pieces of the legislative framework. Together, these components work to create a strong foundation for an improved continuing care system. Alberta is the first jurisdiction in Canada to have one overarching legislative framework for the full spectrum of continuing care services and settings, from home and community care to facility-based care to end-of-life care, as well as supportive living accommodations. While the old legislative framework covered these same areas, the new legislative framework now brings all of these categories under one piece of legislation and more clearly and effectively defines each category. Home and community care reflects the same scope as what was the home care program. Supportive living accommodations are licensed settings that provide supports focused on safety, security, or personal welfare, as well as the provision of meals or accommodation services. These sites are not contracted for publicly funded facility-based care. Eligibility and services are variable and determined by the operator. Continuing care homes are licensed settings that provide 24/7 publicly funded facility-based care and services. Admission is based on the assessed unmet needs of individuals. These settings were formerly referred to as long-term care, including nursing homes and auxiliary hospitals, designated supportive living, and now include publicly funded hospice spaces and settings. We'll talk more about these categories later in this presentation. The Continuing Care Act begins with a preamble, which highlights core principles that are important to the continuing care system. These concepts are reflected throughout the new legislative framework and are foundational to other transformative initiatives underway in continuing care. This also aligns with key principles that emerged through the facility-based continuing care review. The key principles identified in the preamble include: the continuing care system is guided by and provides continuing care in accordance with the principles in the Alberta Health Act. Respect for the diversity of Albertans in continuing care. Commitment to ensuring that the delivery of continuing care is based on a person-centered approach. Quality of life of residents and clients is the highest priority for the Government of Alberta. Family and friend caregivers play a significant role in the lives of continuing care residents and clients. Staff who are well trained and supported enhance the quality of life of residents and clients. Supporting the wishes of residents and clients to age in place or in community and to remain living as a couple or with a companion. Residents and clients deserve to be treated with dignity and respect, taking into account their physical, mental, social, spiritual, and cultural needs. There are two new regulations under the Continuing Care Act. The Continuing Care Ministerial Regulation establishes the goods and services provided through facility-based care, home and community care, and supportive living services. This regulation also establishes cost responsibility for goods and services, including the Continuing Care Home Resident Accommodation Charge. The Ministerial Regulation identifies that supportive living accommodations have 4 or more residents. The Continuing Care Regulation addresses the topics listed on the slide, including exemptions, licensing, staffing requirements, and other operational details such as reporting requirements. More information on some of this content will be presented in this overview. By bringing the content from different acts and regulations under one legislative framework, many of the changes are structural. This means that practice won't be required to change, but there is now legislative oversight or content that applies. Where legislative changes may have an impact on current practice or operations, the updates are intended to modernize the legislation and make it functional going forward. In this presentation, we will cover those more significant changes that may impact you. It's important to note that while changes may have an impact on how care and services are delivered over time, most processes, requirements, and responsibilities will remain similar. The new Act and regulations introduce new terms for the different continuing care settings and services. The most significant change is the new classification of continuing care homes, which brings under one term the settings formerly known as designated supportive living, or DSL, long-term care, and introduces into scope publicly funded hospice spaces and settings. We now refer to home care as home and community care, and licensed supportive living or non-designated supportive living is still referred to as supportive living accommodations. The new continuing care legislation now reflects the existing types of publicly funded home and community care in Alberta. There are 3 types of home and community care. Type 1, when the Regional Health Authority is the provider. Alberta Health Services is the regional health authority and delivers many of the care-related services in the province. In this category of home and community care, services are delivered directly by AHS employees. Type 2, when a home and community care provider is contracted by Alberta Health Services. In this case, home and community care services are delivered by a separate organization from AHS, but under contract to the Regional Health Authority. Type 3, when home and community care providers are directly hired or arranged by clients themselves. Examples include self-managed care and client-directed home care invoicing. The definition for supportive living accommodation includes congregate settings where services are arranged for or provided by the operator, meaning they are not publicly funded for facility-based care, and the operator determines admission criteria. As this definition is slightly broader than under the Supportive Living Accommodation Licensing Act, some additional settings may be required to be licensed as supportive living under the Continuing Care Act. The minimum threshold is that they provide one or more of services to support the safety, security, or personal welfare of residents, and they provide one or more of services such as meals, housekeeping, or other hospitality-like services. Continuing care homes is a new term intended to reduce the complexity of legislation in Alberta for these settings. Under the new legislative framework, all continuing care homes must be licensed, and there are 3 types of continuing care home licenses, which differ based on the levels of care provided at each site. The new license types enable Alberta Health to set expectations that consider the demographics of residents, risks, and settings. It also allows us to retain some of the existing differences between these settings without significantly disrupting the continuing care system. It is important to note that these new terms do not change the services currently provided in these settings or the assessment or admission criteria used to access these spaces. A continuing care home may have one or more types depending on the level of care provided at that site. Type A is what was previously known as long-term care and included nursing homes and auxiliary hospitals. Residents of Type A are individuals with complex medical needs who can't safely reside at home or other types of continuing care accommodations. Type B is what was previously known as Designated Supportive Living, or DSL, and includes DSL 3, 4, and 4D for dementia. Residents in these settings are individuals with complex medical needs who can't safely stay at home or in supportive living accommodations, but do not require the type of support provided by a Type A continuing care home. Type C, we are also bringing publicly funded hospice spaces and settings into the new legislative framework. Type C continuing care homes house individuals approaching the end of life with a life-limiting condition. Admission typically occurs in the last 3 months of life based on assessed unmet needs. Alberta Health sets provincial expectations for quality in continuing care through the Continuing Care Act, regulations, and standards, as well as other associated policy tools. In this section, we will focus on standards. There are 2 types of standards for continuing care in Alberta. Accommodation standards establish minimum standards of accommodation services, such as meals, building maintenance, security, social or leisure activities, and housekeeping to promote safety, security, and quality of life for residents. The Continuing Care Health Service standards establish the minimum standards for publicly funded care in the provision of high-quality, comprehensive, individualized services based on the assessed needs of each client and resident. We are maintaining the current state for the application of standards. The Continuing Care Health Service standards apply to Type A and Type B continuing care homes, as well as Type 1 and Type 2 home and community care. The accommodation standards now have a new naming convention to incorporate the terminology outlined in the legislation. The standards are now referred to as Accommodation Standards Continuing Care Home and Accommodation Standards Supportive Living Accommodation. The Accommodation Standards Continuing Care Home has 2 chapters. The first for Type A continuing care homes, and the second is for Type B continuing care homes. Chapter 1 is modeled after the long-term care accommodation standards, and Chapter 2 is based on the supportive living accommodation standards. There are a small number of continuing care settings and services that are not required to adhere to standards due to a variety of reasons, for example, the nature of the services provided. However, other quality assurance mechanisms are in place for these settings, such as accreditation, contractual requirements, as well as regulatory expectations around duty to notify or complaints related to health, well-being, and safety. Alberta Health's approach was to focus on making updates that result in positive impact for residents and clients. The updates to standards are mostly minor, with a small number of updates that may have moderate implications for some operators and providers. Updates have been made to align standards with the new Continuing Care Act and regulations, improve residents' and clients' quality of life, including increasing their involvement in decisions that affect their lives, increase protection for residents and clients based on key learnings and recommendations as a result of the COVID-19 pandemic, and incorporate minor edits, consolidation, and removal of redundancies. These updates to the standards are a first step. Alberta Health will conduct a comprehensive review of existing standards to support future updates. The comprehensive review of standards will include engagement with stakeholders across the continuing care system. Informed by COVID-19 learnings, including recommendations from the Office of the Auditor General, the standards related to contingency planning have been broadened to incorporate expanded requirements for operators and providers. Updates include, but are not limited to, practicing and simulating plans routinely, involving other parties in contingency planning, and communicating plans to relevant stakeholders. In the CCHSS, or Continuing Care Health Service Standards, this would be the continuity of healthcare standard that has been updated. In the accommodation standards, this standard is titled Continuation of Services. The Resident and Family Councils Act has been repealed, but the requirement remains for continuing care homes and supportive living accommodations to have resident and family councils when desired by residents and their families, or where a resident and family council doesn't exist, to ensure there is another operator-led mechanism in place that fulfills the same purpose as a resident and family council. The intent is to continue to reinforce resident and family participation in decision-making on matters important to them. We want to enable current resident and family councils to continue to function as they are. Now we will be discussing staffing requirements within the continuing care regulation. These requirements are only applicable to Type A and B continuing care homes, which are formerly long-term care and designated supportive living. These are not applicable to Type C or hospice operators or home and community care providers. The previous nursing homes operation regulation was outdated and did not reflect hours of care actually being provided. For example, Type A long-term care operators in Alberta are actually funded to provide an average of 3.62 worked care hours per resident day, which is significantly above the 1.9 hours minimum in the old nursing homes operation regulation, which is almost 40 years old. Only one province includes minimum hours of care in legislation, as this number is inevitably always out of date and thus has no meaning. Furthermore, there were no legislated staffing requirements for designated supportive living, so we are adding legislative staffing requirements to these settings for the first time to increase oversight and accountability. There are two main aims for this new regulation. The first goal is to ensure there are minimum staffing requirements for both Type A and B continuing care homes to ensure accountability and oversight. The second goal is to ensure flexibility for the wide range of resident needs and a wide range of continuing care home settings and sizes, including former long-term care, designated supportive living, levels 3, 4, and 4 dementia, as well as small sites, large sites, and sites that are co-located with acute care. While this regulation content is more flexible, it does establish clear expectations regarding minimum staffing and expectations to ensure resident care and safety. For example, the regulations retain the requirement for a regulated nurse to be on site and available to provide care at all times. Operators will also be required to have a staffing plan, which I will get more into shortly. In addition to this regulation content, the Continuing Care Health Service Standards also outline the minimum standards of care that every continuing care home operator must follow, including standards for care plans, bathing frequency, staff training, etc. While these are not all direct staffing requirements, they do relate to staffing and ensuring that staffing meets resident care needs. Operators currently develop and implement staffing plans, so this will not be a change from current practice, although it is new in legislation and we are adding a requirement for transparency upon request. We are enabling some additional flexibility for operators to staff their sites in a way that best meet the needs of their residents. This expands current state for Type A continuing care homes, as previous long-term care legislative requirements were more stringent, such as 22% of care must be provided by a registered nurse. This formalizes current state for Type B, or designated supportive living, based on what is currently in practice, As I mentioned, there were no staffing requirements specific to DSL in previous legislation. A staffing plan is an operational document that shows how an operator is staffing their site in order to meet resident needs, as well as demonstrate compliance to regulatory requirements. For example, it would include how many of each type of staff are scheduled for each shift. Operators already have operational documents that illustrate their staffing plans in place and are required through some contracts to provide them to the Regional Health Authority upon request. At least 2 clinical staff members must be on site and available to provide care at all times. At least one of these clinical staff must be, in Type A or formerly long-term care, a registered nurse, RN, certified graduate nurse, CGN, or registered psychiatric nurse, RPN. There is a slight change here to expand the role of RPNs in Type A. They will no longer be required to have an RN or CGN on call if they are fulfilling the 24/7 nurse presence requirement. In Type B, formerly designated supportive living, the requirement is for a licensed practical nurse, LPN, RN, CGN, or RPN. Former designated supportive living level 3 sites are an exception to the 24/7 regulated nurse requirement, given the lower complexity of the resident population. These sites have a healthcare aide 24/7, but not a regulated nurse. Under charge nurse, regulated nurse means an LPN, RN, CGN, or RPN, including graduate nurse practitioners and nurse practitioners, and this role provides oversight over the provision of health and other goods and services on a shift. This aligns with current state requirements for Type A and current practice in Type B. With respect to nurse practitioner physician requirements, the regulation maintains the previous requirements for long-term care from the Nursing Homes Operation Regulation and the Continuing Care Health Service Standards. Each resident must have a most responsible practitioner who is a physician or nurse practitioner. The regulation also requires Type A and B continuing care homes to employ a director of care who is a regulated health professional. This was formerly known as the Director of Nursing in nursing home legislation. It has been changed to Director of Care to reflect that the position is not limited to nursing professionals. The role of a Director of Care is to oversee resident care needs and clinical staff. They will have authority to delegate their duties to other clinical staff on site as needed. As in current practice, a staff educator and administrative leader are required, although some flexibility has been added to support these roles. Also in line with previous requirements, Type A continuing care homes will continue to be required to have a medical director who is a physician. Type B continuing care homes may have a medical director but are not required to. This aligns with current state, where some, but not all DSL sites have someone in this role. If an exemption is appropriate, nurse practitioners may also be the medical director. There is now a separate staffing guideline document, which is new. This guideline includes high-level descriptions of what these roles entail, as well as clarification around role titles. At each site, what matters is that people are fulfilling the role requirements regardless of their job title. Example, an administrative leader may be called an operations director or an administrator. Alberta Health has many mechanisms outside of the requirements and regulations and standards that are currently in place to ensure operator accountability, quality care, and resident safety. For example, operators are required to follow the conditions and accountabilities required in their contracts, which set minimum expectations for use of funding, reporting, and expectations for certain staffing roles. For example, professional therapy and allied health roles, healthcare aides, etc. Alberta Health also mandates that all continuing care home operators must be accredited. Resident assessment and quality indicator data is monitored. Alberta Health and Alberta Health Services monitor financial data to compare the funded hours of care against the hours of care provided in continuing care homes. Contracts and funding agreements with publicly funded continuing care operators specify the staffing mix and hours of care required based on the needs of the residents at that site, and external auditors ensure this is delivered. Alberta has successfully used this robust approach to accountability for many years and will continue to do so. Budgets 2023 and 2024 included funding to incrementally increase direct hours of care in continuing care homes in response to recommendations from the 2021 Facility-Based Continuing Care Review and to reflect the increase in resident needs. Requirements for minimum care hours provided will continue to increase in response to that funding commitment. Overall, the intent for continuing care homes and home and community care is to maintain current practice related to admissions and access. To access care in a publicly funded continuing care home or through home and community care, an individual must be assessed by a regulated health professional to determine unmet needs. If a continuing care home or home and community care is appropriate for the individual's assessed needs, then they are eligible for admission into a continuing care home or home and community care. The requirements are maintaining current practice and continue to require that a regulated health professional, such as a registered nurse, licensed practical nurse, or social worker, completes the assessment. Operators of supportive living accommodations will continue to establish their own entrance and eligibility criteria. Each supportive living accommodation differs, and not all sites can accommodate the needs or preferences of every individual. Housing management bodies will continue to be responsible for operating lodges and determining eligibility and access criteria. The regulations include a new requirement that caregivers of clients receive in home and community care be offered an assessment to evaluate eligibility for caregiver support services. If there is a need for further supports, those will be arranged. The inclusion of this expectation is that the new regulation allows for a consistent approach to assessing and further supporting the needs of caregivers. The legislative definition of caregiver in the Continuing Care Ministerial Regulation refers to a family member or friend who provides support or assistance to a home and community care client, but does not include a home and community care provider. There is increased transparency within legislation on what the goods and services are in each category. However, there is no scope change to what goods or services are provided in continuing care homes. The naming of specific goods and services is updated to better reflect current practice. Most significantly, the new regulations provide clarity around goods and services provided in Type B continuing care homes, formerly DSL. The intent of the new regulations is to set expectation around the provision of goods and services in facility-based care. Please note that the new legislation does not change the existing funding models or current fees and charges. Health goods and services is the collection of publicly funded goods and services that continuing care home operators are required to provide eligible residents based on eligibility and resident need. Example, case management, professional health services, or physician services. These are provided at no cost to residents. The definition for life enrichment services has been updated to refer to services that support the mental, physical, emotional, social, intellectual, or spiritual needs and goals of an eligible resident. Life enrichment services were previously a requirement within the Nursing Homes Operation Regulation. Other goods and services are the remaining health-related goods and services that operators are required to provide to eligible residents based on assessed unmet need, cost responsibility, and operator funding. Residents may be required to pay a fee or a portion of the costs of these services. Accommodation goods and services represent what operators are required to provide residents for accommodation and meals, and what the accommodation charge contributes to the cost of, including food services, housekeeping services, etc. The new regulations maintain differences between Type A continuing care homes and Type B continuing care homes with respect to resident cost responsibility for other goods and services. For medications, supplemental nutrition products, and pharmacist and pharmacy technician services, these goods and services will continue to be covered in Type A continuing care homes at no cost to residents, while Type B continuing care home residents will still be required to contribute to the cost. For personal care services, medical surgical supplies, and assistive equipment, continuing care home operators will be expected to provide these goods and services at no cost to residents only where they have been assessed as requiring these goods and services and funding is provided to the operator for the delivery of these goods and services. The intent of the new regulation sets expectations around the provision of goods and services in home and community care to ensure consistency, transparency, and access to supports and services that maintain the independence of clients. Please note again that the new legislation does not change the existing funding models or current fees and charges. The new legislative framework establishes that a home and community care provider must provide health goods and services and other goods and services to clients in accordance with assessed unmet need and the client care plan. Health goods and services are provided to a client at no cost, including case management, professional health services excluding personal care, palliative care, and end-of-life care. Other goods and services are provided to clients and may include client cost responsibility. These include personal care services, caregiver support services, day programs, home support services, assistive equipment, medical surgical supplies for temporary use, medications, and supplementary nutrition products. When it comes to home and community care, distinct categories and types of home and community care determine what services are provided. This comprehensive overview provides clarity on the diverse responsibilities and considerations associated with each home and community care type. Health goods and services encompassing professional health services, case management, palliative care, and end-of-life care. These goods and services are offered across Type 1 and Type 2 home and community care. In both cases, eligible clients bear no cost for these services. However, these goods and services are currently not provided through Type 3 home and community care or client-directed care. Other goods and services include medication, supplemental nutrition products, medical supplies, assistive equipment, personal care, home support services, caregiver support services, and day programs. In all three types of home and community care, clients are responsible for the costs of medications, supplementary nutrition products, and long-term use of supplies and equipment. Additionally, there is a per diem rate for day programs. For Type 1 and 2 home and community care, clients are not responsible for the cost of personal care, home support services, or caregiver support services. In Type 3 or client-directed care, clients are only responsible for any costs exceeding the publicly funded rate for authorized services if the provider of their choice charges more than that rate. Importantly, clients in this category have the autonomy to select their provider and engage in discussions regarding rates for authorized services with the provider. Prescribed goods and services in supportive living accommodations may include, under safety, security, or personal welfare, this is the monitoring of the safety, security, or personal welfare of residents of a supportive living accommodation through the use of alarms, devices, or systems intended for that purpose. May also include systems or processes to confirm the physical presence and welfare of residents and/or track absence of residents from an accommodation. These monitoring systems do not include fire alarms, carbon monoxide detectors, or systems intended primarily for crime prevention. Also under accommodation goods and services, these may include meals, nourishment services, laundry, housekeeping, etc. In this section, accommodation charge means a charge a resident of a continuing care home is required to pay to the continuing care operator. What's staying the same? Continuing care home operators are required to provide accommodation goods and services to residents, and residents will still be required to pay a monthly accommodation charge, which contributes to the cost of the accommodation goods and services. For context, there are many factors that contribute to deciding what the most appropriate approach is to calculating the yearly increase, including things like inflation rates, affordability for residents, ensuring appropriate revenue for operators, and other funding streams like health funding. At this time, maintaining status quo and using the Consumer Price Index, or CPI, to calculate the annual increase is the best approach, as it is predictable and balances the needs of the operator with the affordability for residents. In terms of changes to the accommodation charge, the following changes will apply. The implementation date for the annual increase has moved from July 1st to August 1st to provide more time to determine the annual increase based on CPI changes. The new regulation has implemented a maximum annual increase of 3.8% for the accommodation charge. This is to protect residents and ensure affordability during times of high inflation. In addition, the minister can still make exemptions to accommodation charges, which include exempting a resident of a publicly funded hospice or Type C continuing care home from paying an accommodation charge, or if a resident is admitted to a Type B or A continuing care home for the sole purpose of receiving end-of-life care, they may be exempted from paying an accommodation charge. A home and community care fee schedule provides increased transparency on current fees charged to clients for other goods and services in home and community care. The cost to attend a day program went up on April 1, 2024 from $10 a day to $15 a day, which reflects inflation and overall costs of the programming. Clients and contracted providers or operators providing this programming were given 90 days notice before the rate changed. At this time, the only fee included in the schedule is a $15 per day fee for day programs. The schedule also identifies a maximum of $300 per month to be charged for day programs. However, clients and family can still discuss with their home and community care provider any concerns over the affordability of these fees and determine if a fee waiver is required. The schedule is posted on the alberta.ca website. There are reporting responsibilities in two key areas that operators and providers must be aware of. Notice to Director. Operators must notify Alberta Health in advance of any changes to continuing care home and supportive living accommodation services or operations. Duty to notify. Operators and providers must report in the event of a client or resident injury, potential injury, or other duty to notify incident. More details will be provided on the next slides. Notice to Director, so any substantial changes to operation, ownership, or provision of services must be reported. A form is available online for operators to report these changes. Examples include change in contact information or name of a continuing care home or supportive living accommodation, change in funding, declaration of bankruptcy or filing of receivership, change in services offered or contracted services, such as if there's an intent to change the provider or cease providing accommodation goods and services or health goods and services, or if there's an intent to cease operating altogether. Notification must be provided at least 45 days prior to the change and must include mitigation planning for affected residents if applicable. The intent is for Alberta Health to be aware in advance of any changes which may affect the quality of care or services for residents. Duty to notify are incidents that are injurious to a resident or client, also known as reportable incidents. Reporting is required about any specific circumstances that pose a risk to the health, well-being, and safety of residents or clients, or would jeopardize the ability of the operator or provider to provide care and services. These include any incident during the provision of services in which the safety and security of a resident or client is breached, such as serious harm, unexpected death, resident being unaccounted for, extensive damages to the site, or unplanned activation of a contingency plan. The regulation also includes the requirement for reporting if the operator or provider has been found guilty of an offense under the relevant legislation, including the Continuing Care Act, the Former Nursing Homes Act, Protection for Persons in Care Act, the Public Health Act, the Former Supportive Living Accommodation Licensing Act, or the Criminal Code. Again, a form is available online to submit duty to notify incidents, and it mirrors the reportable incident form. A person may make a complaint to Alberta Health if they have reason to believe that the operator or provider has failed to comply with the Act regulations or standards. Alberta Health will review the complaint, make inquiries, attempt to resolve the complaint, refer the complaint for inspection, or dismiss the complaint if deemed frivolous, vexatious, or has been resolved. Alberta Health may take any other action that the Director considers appropriate under the circumstances. The Director in this case is a designated person in the License Compliance and Monitoring Branch. The Director can refer complaints to appropriate authorities, such as but not limited to Protection for Persons in Care, the Health Advocate, the Police Service, or Minister of Justice. The Act also establishes complainant protection. The intent of complainant protection is to deter and reduce risk of retaliation where there has been a complaint regarding anything under the Act, regulations, standards, or guidelines. Operators and providers must ensure complainant protection for any person who wishes or attempts to make a complaint in good faith. As per the Continuing Care Regulation, the complainant may request that any identifying information not be shared with the operator or provider or their staff members. However, in special circumstances where the health, well-being, or safety of a resident or client is at significant risk, the Director may authorize disclosure of relevant information if needed. Alberta Health will continue to conduct inspections to ensure operators follow all legislative requirements, including those in the Act, regulations, and standards where applicable, and provide safe care, services, and accommodations. If necessary, Alberta Health will also follow up on any complaints or incidents that are reported. The Licensing and Compliance Monitoring Branch at Alberta Health is responsible for licensing, inspections, enforcement as appropriate, as well as responding to complaints. The current process will continue and is now expanded to apply to all continuing care services and settings. One change in practice is that Alberta Health will be doing all inspections. Previously, Alberta Health Services did inspections to the Continuing Care Health Service standards. In the previous legislative framework, there were no clear authority or clarity for specific exemptions from legislative requirements. Given the broad scope of what's under the new legislative framework, we know one size does not fit all. We already know that there are certain legislative provisions that may be challenging or not appropriate for some operators or providers to meet. For example, we are aware that exemptions need to be considered for designated supportive living level 3 sites that do not currently require an LPN 24/7. This will enable current state for DSL3 given the lower complexity of the resident population who need a healthcare aide 24/7 but not an LPN. As such, the new continuing care regulation identifies a small subset of specific provisions within the legislative framework that are permissible for exemption by Alberta Health when certain criteria are met. This is intended to enable flexibility in service delivery while also setting transparent expectations of what provisions are not eligible for exemption. Exemptions are to be used sparingly and in exceptional circumstances. Specifically, the most important criteria in the continuing care regulation states that Alberta Health is not permitted to grant an exemption unless they are satisfied that the exemption will not impact an operator's ability to provide care in a manner that ensures the health, safety, and well-being of individuals. Exemptions are time limited and may include conditions such as additional reporting, oversight, and/or supplementary requirements to ensure the health, safety, and well-being of residents and clients. Details of the exemption may be published on the Alberta Health Public Reporting webpage. This may include the name of the continuing care home operator and any conditions such as time limits or mitigation for the safety of residents or clients imposed on the exemption. Legislation enables and sets requirements for operators and providers to appeal licensing decisions or administrative penalties. This maintains the approach to appeals that was outlined in the Supportive Living Accommodation Licensing Act, including a 15-day period for operators or providers to appeal a decision. The Act applies the appeals process consistently across continuing care services and settings. Appeal of a stop order or the cancellation of a license will go to the Court of King's Bench, while an appeal of an administrative penalty or a licensing decision will go to an appeal panel. New to the Continuing Care Act is the ability for administrative penalties. However, that part is not in effect until April 1, 2025, after which time appeals to notice of administrative penalty will be heard by an appeal panel. The new legislative framework is just a first step in consolidating the continuing care system under one act. We will continue to work with stakeholders and closely monitor the implementation of the legislative framework and tailor an update as needed. In terms of other initiatives, the Government of Alberta has invested $1 billion over 3 years to begin transformation of the continuing care system and implement recommendations from both the Facility-Based Continuing Care Review and the Advancing Palliative and End-of-Life Care in Alberta report. These strategic investments will support initiatives to shift care to the community, enhance workforce capacity, increase choice and innovation, and improve the quality of care within the continuing care sector. The implementation of the Continuing Care Act and strategic investments to transform continuing care are a major undertaking that will help make Alberta's continuing care system more sustainable, responsive, and flexible to meet the existing pressures in continuing care. Alberta Health is developing and will be distributing communication materials to support your understanding of the legislation. These materials include information guides, overview documents, fact sheets, and others. That content is available or will be made available on the Government of Alberta website, and materials will also be distributed. So please keep an eye out for those online and through your usual communication channels. If you have questions, please contact us at cclegislation@gov.ab.ca. Thank you very much for listening and reviewing this information.